Good evening, friends and chairpersons. At the outset, I'd like to thank Dr. N. Khanna for this kind invitation. It's indeed an honor for me. So I'm going to talk on massive pulmonary embolism as a physician. How do I manage it? So we all know that acute PE is common and it is associated with high mortality if left untreated. However, prompt diagnosis and treatment can reduce the mortality from 30 to 8%. We are all aware of this cascade which happens when a patient has got a massive pulmonary embolism. There's an increase of RV afterload, RV dilatation, increase on the RV wall tension, increased demand of oxygen by the right ventricle. Because of RV ischemia, there is decreased RV contractility, decreased RV output, which causes decreased LV preload, decreased cardiac output, hypotension, and then the patient develops obstructive shock. So basically, there's impaired gas exchange due to VQ mismatch, release of inflammatory mediator, and intrapulmonary shunting, and hypotension is because of increased pulmonary vascular resistance, which leads to RV dilatation, reduced LV filling, and eventual impaired cardiac output and shock. So 2019 European Society of Cardiology guidelines are very useful and very practical to address this, and we follow this. They have given various classes of recommendation depending upon how they would grade the particular recommendation, and also depending upon what is the level of evidence which is available. So what is massive pulmonary embolism? Massive pulmonary embolism is pulmonary embolism with need for cardiovascular resuscitation or sustained hypotension requiring vasopressor support, and there could be a clear evidence of end organ hypoperfusion like cold cramming extremity, confusion, decreased urine output, or it can be a pulselessness or persistent profound bradycardia. So if you look at the recommendation, as soon as you have a suspected PE with hemodynamic instability, first thing which should be done should be a bedside echocardiography or emergency CTPA if your patient is fit to be shifted for CTPA. Before anything further, you should give IV anticoagulation with unfractionated heparin as a bolus dose, which should be weight adjusted. Before you do anything further, high suspicion, ask for an echo and give this, unless there is a contraindication. So CT, Dr. Priya has shown such nice pictures of our patient. Also 2D echo is a very useful bedside modality, and you have to look for various changes like enlarged right ventricle with basal RV-LV ratio of more than 1. So RV is bigger than LV, McConnell sign, flattened interventricular septum, the IVC is distended without any cyclical variation with breathing. You can sometimes find a clot, or there can be decreased CHAPSI and decreased peak systolic velocity of tricuspid annulus. So it's a very useful modality, and I think we are all learning this in last 1 year to do a bedside echo. So if there's a suspected PE in patient with hemodynamic instability, what I do is I do a bedside transthoracic echo. If there's no RV dysfunction, it practically rules out pulmonary embolism. If there is RV dysfunction, if CTPA is possible and feasible, we should do it. If there's no clot on CTPA, this is unlikely to be a cause of shock. If CTPA is possible and it is positive, diagnosis is confirmed. If it is negative, you should think for other causes. Wells score and Geneva score also helps you to know the predictability of pulmonary embolism. Pulmonary embolism severity index is a useful bedside tool to assess the mortality risk to the patient. What do I do after that? I have given heparin. I start oxygen immediately. I get 2 peripheral cannulae and if the patient is hypotensive, carefully administer 500 to a liter of isotonic crystalloid. We have to be careful that we do not overload these patients, because otherwise due to ventricular interdependence, the LV may become small and the LV output may even go down further. High frequency nasal cannula or NIV support is given if the patient is not able to maintain saturation. And this is one situation where you should not run for intubation and ventilation unless a patient has got severe hypoxemia, not improving with NIV, or has an impending cardiac arrest. So it is very important to treat RV failure because this is associated with high mortality, caution fluid optimization, vasopressors, norepinephrine is the preferred one. You can give dovitamin if the patient is able to maintain his blood pressure. And if nothing of this is helping, you have to go on to ECMO. So next is thrombolysis. What we do is, if there's a probability of massive pulmonary embolism, evidence of shock or respiratory failure, I've already given heparin anticoagulation. I've asked for an echo, and echo is proven pulmonary embolism. If possible, I'll do a CTPA. If not, depending upon echo and the clinical scenario, I'll move on to fibrinolysis if there is no contraindication. So fibrinolysis is shown to have more rapid resolution of symptom, stabilization of respiratory and cardiovascular function, reduce RV damage, improve exercise tolerance, and increase probability of survival. However, one major problem with thrombolysis is increased risk of bleeding. So before we go on to thrombolysis, we have to rule out absolute and relative contraindication to thrombolysis. And RTPA is the preferred drug. 100 milligram is given over 2 hours. There's an off-label use of giving 0.6 milligram per kg over 15 minutes if the patient is in cardiac arrest. After this should be followed by heparin depending upon the PTT. However, studies have shown that 8% of the high-risk patient can have unsuccessful thrombolysis, which is characterized by persistent clinical instability and unchanged RV dysfunction on echocardiography after 36 hours. So these are the patients where we can think about catheter-directed thrombolysis, which is one of the newest treatment option of massive and submassive pulmonary embolism with hemodynamic instability. So as per the American College of Chest Physicians, catheter-directed thrombolysis has got class 2C recommendation for acute PE associated with hypotension and contraindication to thrombolysis, or if thrombolysis has failed, or if the patient has got shock. And because of profound shock, the medicine is not going to reach the clot. So here we can do catheter-directed thrombolysis. However, one major problem with this is you have to have appropriate expertise and resources, which is not commonly available. It's available in very few places. I think Dr. Khanna is going to talk about catheter-directed thrombolysis or percutaneous mechanical thrombectomy. He can tell us more about it. One more modality which is available is surgical embolectomy, which can be used, but again, the expertise has to be there. This is usually done along with ECMO. So coming to summarizing, in a case of massive pulmonary embolism, I'll immediately give unfractionated heparin. Systemic thrombolysis therapy is recommended if there's no contraindication. Surgical pulmonary embolectomy is recommended if there's a contraindication or thrombolysis has failed. Similarly, percutaneous catheter-directed treatment should be considered for patient with high-risk PE in whom thrombolysis is contraindicated or has failed. Norepinephrine or dovitamin is the drug of choice as a vasopressor and inotrope in this patient. And ECMO may be considered in combination with surgical embolectomy or catheter-directed treatment in patient with pulmonary embolism and refractory circulatory collapse or cardiac arrest. Thank you for your kind attention.
Thank you, Dr. Priya and Dr. Sudha. That has been a wonderful, this is the way that most of the pulmonary embolisms are treated. But sometimes we do get patients where we have to be more aggressive, and if we have to be more philosophical about it, it's the same thing like we started with acute myocardial infarction. The guidelines started moving up from thrombolysis to high-risk angioplasties and PCIs, and then finally primary PCI became the standard of care. And similarly, the guidelines are moving up across specialties, different vascular societies and European societies for cardiology and vascular surgery, and as well as American societies, moving up for DVT from just heparin therapy or NOACs to acute interventional treatment or lytic treatment for acute DVT to prevent valvular functions in future and to prevent uncover May-Thurner syndrome and to prevent recurrent DVTs and morbidity.